Hi, dear colleagues, welcome back. We are very honored to invite Dr. Zhang Wei to introduce our next session of live surgery mission. And welcome, Dr. Zhang Wei.
Thank you, Fear. Hello, dear colleagues. I'm Dr. Zhang Wei from Hangzhou Traditional Chinese Medicine Hospital. I feel very happy to attend this ISUBE webinar and introduce the UBE liver surgery as a host. Today's UBE liver surgery is broadcasted from the Turkey by our Turkey surgeon, Dr. Hayati, and his team. Dr. Sigdem and Mumuko from Turkey would introduce us the case report later. And I will work with Dr. Wu Peng Huang from Singapore. Indonesia team, Dr. Aslafi Rizki Jatam, and Dr. Hamantia Maha Dipta, who stay online to introduce the UBE liver surgery session. We all know that UBE is a very good technique. I learned this technique from Dawson. As Dawson said, how to protect the muscle is very important skill, and keep the water outflow fluidly is another key factor. The hydrostatic pressure is also important. We often harm the selling back to a high of the 70 to 100 centimeter above the operation field, and anesthesia is also important. The muscle relax allows us to expand our workspace, and you can also use the UB retractor by your assistant to retract the muscle to enlarge the workspace. We look forward this great surgical demonstration. If you have any question during the liver surgery, you can send the question to the chat room, and we will answer these questions. The operation is being prepared. Be sure to observe the every detail of the operation. Thank you, everyone.
Hello, I'm Dr. Wu Peng Hong from Untitled General Hospital, Singapore. I'm delighted to co-host this session with Zhang Wei, and as well as my dear colleagues from Indonesia, Dr. Ashraf and Dr. Hamandia. I would like to introduce our fellow discussants as well. Dr. Tian Dashen from the Second Hospital from Medical University. Dr. Xu Weibing, Dalian Central Hospital. Dr. Yang Hejun from number 3 Provincial People's Hospital. Dr. Ruben, my dear friend from Singapore General Hospital. Dr. Kelvin Pina, Central University Hospital of Asturias. Dr. Musa Ibrahim, Batala Muhammad Specialist Hospital, and Dr. Hijo Abdul Qadir, National Orthopedic Hospital, Dala Kano. I would like to continue the introduction by Dr. Ashrafi Rizki Gatam from Indonesia, our co-host, to continue with the introduction.
Hello everyone. I represent Dr. Rizki Gatam because we have emergency situation surgery. So my name is Harmantia Mahadipta. You can all call me Harman. It is very great to work together with the International College in this UBE's live surgery sessions. So now let's invite Dr. Chikdem Mumchu to introduce us to the case report, today's cases.
Hello, everyone. Can you see my screen?
Yes, we
Yes.
can see.
You can see it.
Yeah. Okay. First of all, I would like to thank you all for attending our webinar. I'm Dr. Çiğdem Mumcu from Turkey.
Çiğdem Hanım'a da kulaklık gerekebilir, mikrofon. Bunu nasıl yapacağız?
I can hear you, Dr. Hayati. I would like to introduce the case which will be performed by Professor Hayati. Today's case is a 65-year-old female patient. She is a housewife. She complains both buttock pain and radiating leg pain on the right side. Leg pain occurs weakness with walking.
Excuse me, can you play your slides?
Slideshow.
Yeah.
Yeah,
We
please
cannot
slide.
see the slides.
Any problem?
Can you play your slides, the presentation?
Yeah, okay. Now, can you see?
We can see it, but
We only see
it's
the
still
first
on the
slides.
yeah, only the first slide.
This is first slide. And
So
now second.
Dr. Muchu,
Yes.
instead of sharing PowerPoint, you share the screen. Then we will be able to see your slide. I think you click share PowerPoint. That's why it's on the first slide. You can, yeah. Now you click share again, and then you click yes. Now we
Okay.
can see.
Okay.
There you go.
Okay. Thank you. Today case is 65 years old female, and she is a housewife. She complains both buttock pain and radiating leg pain on the right side. Leg pain occurs weakness with walking. Her pain increases standing and extending, and decreases with sitting or walking the semi-flexed position. She has claudication in 100 meter. Just 1 second. Yeah. Sorry, just I can have a problem. Just 1 second, please.
Now we see the slides which is introduce the medical history.
Yes. Yeah. Now, okay. Just 1 second. Can you see now? Can you see?
Yeah, yes, I can see, but you
medical
better share
history.
your slides. Please the button.
Now? Can you see?
Yeah, yes, I think, yeah, it's okay.
Yeah, medical history, right?
Yeah.
Can you see my slide, medical history?
Yeah, yes.
We can see.
Okay,
It's a bit small.
Yes.
Yeah, but it's okay. We can see.
She was operated twice due to lumbar L23 and L3 for disc herniation in another medical center in 1999 and 2016. She has had pain in her waist on right leg for 6 months. Pain is increasing when walking and standing, loss of strength in the right knee and pain in the right ankle. Her score, ODI 42, visual analog score is 8, Zurich claudication questionnaire 51. her physical examination,
We cannot see your next slides.
Sorry?
You can play your slides. We know is still of the medical history. We cannot see next.
Okay.
Next one we cannot see.
Just 1 second.
Hello, Dr. Manju. I will
Yes.
help you to share the screen, and then you can just introduction. I will share the screen for you for the case.
Can you see now? My screen, can you see?
Yes, now it's okay.
Yeah,
Dr.
yeah.
Manju, I think Lina will share the slides. Then you just talk when Lina play the slide. I think it's probably working better for the current setting.
Yes, I'm sharing. Dr.
Okay.
Manju, you can continue.
Okay, thank you. Move on, please, Lina. Her physical examination, lumbar spinous processes are painful with palpation, and lumbar movements are painful and restricted. LASIK test was positive in right lower extremity on 40 degree, motor weakness in right lower extremity, and weakness in right ankle dorsiflexion. You can see her X-ray and yeah, move on, please, Lina. And you can see MRI L45 level. She has stenosis, femoral stenosis. And the other images for MRI images. And
Lina, show the previous slide.
yeah, Lina. Yes.
No, the one
Next
before.
one.
After
Yeah. Diagnosis is L45 lateral stenosis and L34 and L45 femoral and lateral stenosis. Operating plan is Dr. Hayati's operating plan is to perform unilateral biportal sublaminar contralateral decompression for L45 by left approach, and also if he has time, he will perform right side femoral approach, femoral UBE decompression L45, maybe L34, and yeah, that is all. I think. Thank you. Any question?
Now, everybody hear me? Thank you, Dr. Chidam.
Yes, Dr. Hayati, we can hear you.
Yes, Dr. Chidam, thank you very much for your case presentation. Now, we are ready to perform. Now, we are ready to perform the endoscopy now. The case operated previously 2 times. And is it possible to see? Yeah. There is 2 different incisions, paramedian incisions. Actually not so paramedian, it's the right-sided incisions. But the case has 2 level problems, L45 and L34. We did the paramedian injections to identify the responsible level. In our same day, we believe that mainly the L45 is responsible for the symptoms. Now, if you notice in MRI, we have a big issue. The right 4-5 foramen is completely narrowed. And there is two different issues. Flavum and the calcified disc occupied the foramen. Now you see this is the previous operated case, and the tissue is a little bit different than normal, of course. And now we are on the lamina, left side lamina. The 9 o'clock is the cranial side.
Sorry, we
And,
cannot see the camera.
Can you?
We can see it.
We can
Yeah,
see
you
now.
cannot see the camera, okay? Now can you see the camera? Endoscopy?
Yes.
Yes.
Okay, okay. Okay.
Now we are on the lamina, right side lamina. And here is the interlaminar foramen. And the 9 o'clock is the cranial side. And the 6 o'clock is the medial or left side. And the 3 o'clock is the caudal side. Here is the interlaminar foramen here. Everybody see, I think, right?
Yes, we can see.
Okay. Now I'm creating a working space for me. Okay, now, further. Okay. Arif.
Dr. Hayati, how much pressure do you use in the water flow?
Water, yes. You know, there is another option to adjust the hydrostatic pressure on the surgical area. One, you can use the arthro pump, or you can use the distance between the fluid and the gerund or patient. I'm using just the fluid distance from the patient. If you have about 1 meter from the case, from the patient to the fluid bag, you can obtain about 30-50 millimeter mercury hydrostatic pressure, which is enough and available for the surgery.
Okay.
0 or 30-degree endoscopy for today's case?
Now we are working with the 0.
Or 0.
Yeah, this is the 0. Now I will create a working space, true working space. Now we are working on the sun space. Dr. Sun described the rural area. There is a rural area on the lamina. There is no any ligament or muscle attached to this area, and we can use as a potential working space. Now, also, this case received 2 times physical therapy. Tansiyonumuz kaç? Tansiyon kaç?
So, Dr. Hayati, you use the speed burr combined with the suction?
Yes, but not. It's pre-suction. Just I put the hose for the drill to remove the debris and the bony particles and the blood clots. But I'm not using the forced suction, just free suction.
And on your speed burr, you have an opening side pointed on your lens. Do you have any experience breaking the lens using that kind of burr?
Sorry, can you ask again, please?
Sorry. So did that kind of speed burr have an opening side pointing towards your lens, right?
Anladın mı Samet? I couldn't understand you.
Hello, can you hear me? You have a speed burr with the opening
Yes.
side. Can you hear me?
Yes, I'm hear you. Yes, high speed burr, okay.
Hello. Maybe I have a bad connection.
I can hear both of you. I just translate. So the cutting burr is facing towards the scope lens. So Dr. Haman is asking, do you have any problem with drilling your lens?
Sure.
Maybe you can't hear us, yeah.
I will turn you after removing some bone from here then.
Okay.
Dotson prefer to use the gravity suction when he uses this kind of the shiver bone. His assistant often controls the button.
Yes, I'm using the nurse control for the hydrostatic pressure adjustment. When I working with the drill, my assistant close the hose. But
When
I'm
you,
using after CD Dura.
Yeah,
Not right now.
the assistant will close the soft tube connect to the shiver
Yeah,
bone.
we are using the soft tube to adjust
good
the
habit.
hydrostatic pressure during the high speed working.
Yeah.
When we break in the break time, the nurse make free the hose to remove the debris. You can see now she is closing the hose. Okay, and now opening the hose.
Now the
Closing
sister
the-
close.
Yeah.
Stop work.
Yes.
Then open the soft tube.
Yeah. Açalım. Kapatalım. Açalım. Kapatalım.
Is a good method, I think, to keep the surgical field clear. When you use the burr to remove the laminar.
Şu mikrofonları bana yaklaştır. Hiç anlaşılmıyor. Keşke kulaklık kullansaydık. Hayır. Şu su birikmesin çok. Okay. Bakayım tur. So I have a question for you. When I stop the laminotomy, when I should stop it?
When we have found the proximal insertion of the flav ligament, then but for this, I think, especially for the contralateral sublaminar approach, I will remove more the laminar. Then especially for the 0 degree, you have the enough the space to observe the contralateral side, the nerve root, and the tip of the SAP. So For the contralateral sublaminar, I recommend move more the laminar. And can you show us the location of the portals on the
Sorry?
CR? The location of the two portals. We
Yes,
want
you
to
can
know
see.
the
Now,
position of the two portals.
yeah. Okay, yes, you can. Now, do you see this?
Dr. Hayati, do you use a higher portal for your contralateral approach? That's actually probably what we are talking about than your usual than your usual interlaminar approach for contralateral approach. Do you use just a little bit higher portal?
Yes, a little bit higher. If you notice that here is the disc level. Okay. For the contralateral, a little bit higher is better than. Sure. Şurayı kapat. Açalım. Kapatalım.
This area is basement of the spinal process. We must make enough space for the decompression of the contralateral side. So for this case, we must remove more the bone of the in the area of the basement of the spinal process.
Here's the midline, you see.
The cleft.
Yes, the cleft. Whatever.
I prefer to use the 30-degree endoscopy to do the contralateral.
Yes, sometimes, yes,
decompression.
you're right. Sometimes I'm using the 30-degree. If I need, now it's okay. I will change the my camera with the 33. Okay. Whatever.
Dr. Haman, do you use the 30 or 0 degree?
Yeah. I usually use 0 degree, but
actually for the contralateral side.
Yeah. But
for the contralateral side,
cases,
generally the 0 degree is enough actually. But if you want to see the ipsilateral upper foramen, maybe 30 degree is useful. But for the contralateral side, generally 0 degree is enough.
yeah, if you use 0 degree for contralateral side, you may have to do a lot of bony work. But if you use 30 degree, you can minimize your bony work on the contralateral side.
Dissector.
So I find that doing with the 0 degree, you can see the exiting nerve root, just the axillary fat and a little bit of the bottom of the contralateral L4 or this L4-5.
Yeah.
While if you use the 30-degree scope, then you can see the entire L4 shoulder and the axillar part of the L4 nerve root. For the purpose of decompression, usually we tackle more of the bottom of the nerve rather than the top. So probably 0 or 30-degree scope can do the job. So what I do is I do everything with 0 degree, and then if I have time and I'm not in rush of time, then I put in a 30-degree scope to evaluate the adequacy of decompression. Just for convenience, I think I'm used to using 0-degree scope.
All right. Now here is the contralateral side. You can see the facet joint hypertrophy just here. The sector usually. Now you can see the hypertrophy of the contralateral side.
The facet joint of contralateral side.
Yeah, yes. Yes. Şimdi disektörü alayım bakayım.
How do you think the apsilateral side, the foraminal decompression? I think there is a limitation because you can only see the axillary area of the exiting nerve root. But for the contralateral side, you after removing the tip of the SAP, you can see a long area of the exiting nerve root.
You're right. Yeah, always I prefer if I need more than half of part of the lateral of foramen, I prefer to use the contralateral side. Generally, we are removing the flavum partially. First of all, we're removing the just superficial layer, after then deep layer. But in this case, you see both of layers are coming together because of degeneration. And also, if you notice that there is a severe hypertrophy, and you see here, the facet joints start to the calcification. It became like lamina. Here is the lower lamina, actually.
Dr. Hayati, when you remove the flavum ligament, do you always do like this one, piecemeal technique instead of en bloc resection?
Yes, generally I'm using the en bloc resection.
How do you find it more useful, using piecemeal or en bloc resection?
Piecemeal, yes, you have to remove the piecemeal if the ligamentum flavum became calcified. Impossible to remove the as a one part, single part foraminal. This is yes, this is almost calcified. You see here. Here, this is the inner part of the flavum, deep layer of the flavum, almost calcified. So we cannot remove as a one part. We have to remove as piecemeal like this. If you're sure about there is no any adhesion between the flavum and the dura, you can make total or one part en bloc resection. But in this case, almost impossible. Foraminallar.
Can I
See
ask?
here? Of course, please.
Uh-huh. When should we stop to do laminectomy for contralateral side decompression?
Okay, very nice question. You know, actually, the stenosis surgery is a kind of lateral recess surgery. If you do enough lateral recess decompression, you can expect good results. And the lateral recess narrowed by bone and the soft tissues. So we need to do bony decompression and soft tissue decompression. Arif, tool ver bana bir. When you see the flavum, border of the flavum bilaterally, and when you see the cleft of the flavum in the proximal, and when you see the lower lamina in the caudal side, you should stop the laminotomy. Okay? In other words, when you see the lateral fat pads of the dura, maybe you can say that, okay, it's the body decompression enough.
Thank you.
Can you tell us the blood pressure during the spray? The blood pressure.
Blood pressure.
Yeah.
Blood pressure is about 75.
75?
Yes, 75 to 50. Always prefer the low hypertensive anesthesia.
Oh, it's not easy to make the blood pressure. You mean systolic 75?
Yeah, we have very effective anesthesiology team.
No wonder your
Also,
surgical field is so clear. I mean, I don't know whether I can get my anesthesia team to get a systolic of
Yes,
75.
very clear the surgical field. I think the lower blood pressure is very important.
Yeah.
Blood pressure is very important in all the spine surgeries, you know. Even in scoliosis surgery, open degenerative surgeries. And also we are using the ejection table to adjust the tension. You know, the abdominal, the free of the abdomen is very important.
You have very excellent anesthesia team.
Yeah. Yes, I'm very lucky, Kirsten.
We are all lucky.
Yeah. Otur. Suyu kapatalım. Açalım. Burayı kapatmışım zaten. Açalım. Kapatalım. Açalım. Kapatalım.
I want to say how to select between 30 degree and 0 degree arthroscopy in the management of lumbar spinous stiffness. Thank you.
Yes. If you want to see the upper foramens bilaterally or ipsilateral upper foramen, I'm choosing using the 30 degree. Okay. Şuradan bir çıkaralım bakalım onu tekrar.
In my opinion, no, the apsilateral, the laminar, is blocking the endoscopy. The left side, the laminar, yeah, the apsilateral laminar, I think. But if we rotate the 30-degree, we can see the more large the surgical
you're right.
contralateral side.
Yes. Teşekkür ederim. Some adhesions can be seen, so we should be careful. You see the compressed area here.
Yes.
Yeah. Alayım gene punch. Just want to demonstrate the bony compression on the contralateral sides. Okay, teşekkür. Bir tane Japon alayım. Şunları alayım. Need epidural ligaments, huh?
Severe hyperplasia of the facet joint.
Sorry?
I mean the medial margin of the SAP is very large.
Yes, you're right. Because of hypertrophy, yes, I said before, very large. Foraminal bir daha alayım bak şimdi. Always following the UB decompression procedure steps. Laminotomy, flavectomy, total flavectomy, and the bilateral facet joint management, and the bilateral foraminotomies, upper and lowers, or foraminal entry enlargement, and then, if needed, disc management.
What is the degree of the Carson punch?
Carson punch is about 20 degree. I'm using some curvature punches to reach the foramens.
Curved Carson punch.
Yeah. What is?
Dr. Hayati.
Yes.
When do you use curved punch, Carson? Ipsilaterally or contralaterally?
Yes, generally I'm using ipsilateral, and also sometimes using for the contralateral upper side, or contralateral cranial foramen. Dissector.
I think if you want to if you want to remove the left bone of the IP or ipsilateral side, you can use the curved the Carson punch.
Yes. Okay, Carson bakayım abi düz.
This area is corner, the contralateral corner area. It is the junction of the upper margin of the laminar and the median margin of the SAP.
Yes.
This contralateral, this part is when Professor Zhang like to use a jump bottle to bite this part, right? This corner.
I prefer to use the third portal to deal with this area. Yeah.
Contralateral corner.
Yeah. Because it's difficult for us to remove the bone of the upper margin of the laminar or contralateral side. The angle of the Carson punch is not very good, but if we choose the third portal, it's very easy. I think the upper margin of the laminar area decompression is very important.
I use an osteotome for that. I think Dr. Haman, I saw you also use osteotome for that before. we meet up so often, I kind of see each other's technique. Yeah, correct,
Yes,
Dr. Haman?
Yeah. Sometimes I use osteotome, but nowadays I tend to use a diamond burr. It's easier. It's easier for us because if you use osteotome, you need assistance to hit your osteotome. But if you use a diamond burr, you can work freely, even though to the upper lamina of the contralateral side.
Yeah.
It seems that there is no diamond burr, diamond shiver burr.
Yeah,
Pardon me?
didn't use diamond burr. If you don't use diamond burr, it's very hard for going to the contralateral side. You don't really dare to. You use cutting burr, flute burr, very hard to drill down like that. I mean, it's quite scary. So diamond burr is okay.
Diamond burr is safe.
Safer.
It's more safer than the cut burr.
For the corner, for the corner especially, and
yes.
the midline caudal lamina. Yeah. This part, that's what we are all curious what Dr. Hayati also use osteotome.
Osteotome, yeah.
Yeah.
Güzel. Vuralım.
Do you perform the diagnosis injection before the operation?
Sorry?
Dr. Hayati?
Yeah, we did, yes.
Injection.
Yeah, actually I said that, yes, we did in the same day to identify the responsible level, because if you notice that there is two right side foraminal narrowing in this case. So we did injection to identify the responsible level. Osteotome açılım.
This patient has both sides the bottom pain. Do you do the ipsilateral decompression?
If I, well, yes, we will do the ipsilateral
the
for the upper level.
contralateral. Maybe the contralateral can be handled safely with the project.
Dr. Hayati,
Yep.
are you cutting the basement of the contralateral SAP just now?
Yes. Yeah, no, yes, we are just on the this is yes, the SAP.
Yeah, yes.
Here,
Is there any,
the lower part, and here is the axilla.
is there any instability?
If you go more, of course, you can face with some instabilities.
You can remove more medium.
No, just hypertrophy.
Yes,
When
these
you
are
see, you can go more to see the contralateral side pedicle bisectorally. Değişsin. Here is the pedicle. Okay, this is the foramen, and here is the axilla, nerve root. But I want to remove this part. Hypertrophy part. Açılı osteotom.
Thank you.
Next time, maybe you can try the transportal.
Yeah.
Actually, Dr. Hayati, I'm curious, why not we keep the ligamentum flavum before we do this osteotomy? You have a very experienced assistant, you know, but sometimes I get a bit nervous if my assistant isn't experienced and then there's no flavum and I'm knocking on the contralateral side.
Yeah, before the laminotomy, I always keep intact the ligamentum flavum. But I always following the ligamentum flavum borders. If you can remove all the borders of ligamentum flavum, if you can remove the ligamentum flavum, all the borders like this, you can be sure about the full decompression. Because ligamentum flavum is attaching the pars, inferior part of pars, the inner side of the upper lamina, and the over and the tip of the lower lamina, and the bilaterally the inside the proximal part of the nerve roots. So if you remove all the flavum completely, you can be sure about your decompression. What's that time? Şimdi bir kerisini punch alayım.
Good morning, Dr. Hayati. Good morning, Dr. Hayati.
Sorry?
Good morning.
Good morning.
I just want to ask a little question.
Of course.
I am just very much surprised at the skill of your nurse. How long did it take you to train her? fantastic nursing.
Can you ask again, please? Samet, dikkat etsene.
I said, I'm very much seeing the skill of your operative nurse. She knows exactly what you want, exactly how to hit on your instrument without causing injury. How long did it take you to train her?
Ne dedi?
Söyleyeyim mi?
Söyle abi ya.
Hemşireniz çok yetenekli. Onu bu hale getirmek
Yeah.
ne kadar zaman aldı?
Yes, she is beautiful and very skillful. She's working more than 2 years.
Oh.
It's very, very important.
Very quickly.
Nurse also is very important. Okay.
She is our princess.
Congratulations to have her.
Thank you. Now you see the tip of SAP here. Can you see? Here. Very long. It's reaching till here. But the disc level is just here and it exceeds the disc level. Even the patient in prone position. I will remove this from here. Okay? Bir tur versene şurayı bir test.
Why not remove more medial margin of the IEP?
More medial?
Medial margin of the contralateral side IEP.
I think he's doing it now. Removing some IAP.
Okay.
I will do. Don't worry. Kerisini alayım. Aref versene şunları yakayım. Bunu azıcık yükseltsin. Bakayım. Şunu bir geri çek.
Arif 3 yapar mısınız?
Bu çalışıyor mu ki? Değiştirmiş mi sen? Değiştirmiş.
Dr. Wu, my internet is not very good.
No, yeah, but we hear you clearly, Dr.
Okay.
Zhang.
Bir numarayı alayım.
How many % of facet joint still alive there?
Yeah.
How many %?
Yes, according to the literature, you can remove less than 50% of facet joint if you don't touch the facet capsule. Facet capsule stability is important than the removed part for the stability.
Did we remove some of them here?
Yeah. Bu çalışmıyor. Biri değiştir. Okay. Osteotom açılı.
Actually, I do MRI for quite a number of my patients at 6 months, and removing this amount of facet on the MRI doesn't look much actually. The nice looking hamburgers like facet is still quite, I mean, probably less than 50%.
Actually,
what I can see.
You can refer to the medial margin of the pedicle during the surgery.
Okay.
About 1/3.
Yeah.
1/3? Okay.
If you see the pedicle clearly on the contralateral side,
yes,
you might be about 1/3 of the contralateral facet. And then we are undercutting, so we are only taking the ventral part of the facet. So it's not a lot of facet.
Hello?
This is the pedicle. You see here? Yeah, this is the pedicle and inferior foramen here. Now we will do the SAP removing a tip of SAP just here. Osteotom açılı.
Sence ne yapalım?
The dorsal part, the dorsal bone will also be removed. of the pedicle? The
Yeah,
dorsal
possible.
part of the
Possible.
pedicle.
Possible. You should consider the spontaneous fusion of the facet joint also. For example, in this case, the contralateral side facet is almost fused spontaneously. There is a spontaneous stabilization also. And I'm not scared removing a part of the facet joint. Now you can see clearly the joint line. I will show you this sector.
Okay.
This is the joint line of facet joint here. You see here?
Yes.
This is the joint line, okay? This is the joint line. And here is the disc level and the tip of SAP. Yeah, the disc level here and the tip of SAP. Now, there is some adhesions between the disc and the dura, the contralateral side. We will try to make a release with this.
Very clear.
Yeah.
Could you please touch the pedicule?
This is the disc, calcified, ossified disc. You see here? And the tip of SAP here. It should be here, but now it exceeds the disc level. Even the patient is laying down from position. When your patient start the walking or extension, because of loss of disc height, these parts will be touched to the nerve root, these parts. If you couldn't remove this part, yeah, if you couldn't remove this part completely, you cannot solve the problem.
Yes.
You can do everything perfect. You can do very nice decompression. You can make very nice picture, but impossible to solve the problem. You should remove this part from here.
If you will not remove this part, maybe the patient stand up, it will cause another symptom.
Yeah, if you cannot remove this, you should add the contralateral or right side paravertebral approach to make additional decompression for the foramen. And during this procedure, you should know that the nerve root just here, okay? But the nerve root behind the superior part of annulus. Here is the annulus, okay? This is the calcified annulus here. Did you see here? This is. If you keep intact this annulus, you can use the radiofrequency safely with this area, okay? But if you exceed this annulus part, superior part, you can touch to the nerve root with your electrodes. We should be careful about this. So I always trying to preserve this part intact. Just I will make free the behind of this part.
What is the patient's blood pressure now?
Yeah.
During surgery.
Çok dikkatli tutalım. İş çekmeyelim. Öyle duralım.
The patient's blood pressure.
Sorry?
Patient's blood pressure.
The patient's blood pressure
still 75. Same. Never change. Our team doing a multimodal anesthesia. then they can maintain without any problem the lower hydrostatic blood pressure.
You measure the arterial pressure or cuff pressure.
Yeah. Okay.
You change another IF.
Yes. Şimdi osteotom alayım. Here's the joint line, and I will remove this part. Vuralım. Bir dakika, vuralım.
Expert of South Korea prefer to use the curved osteotomy.
Sorry?
Some of the experts in South Korea prefer to use the curved osteotomy.
Yeah. Yes. I have 3 different type of osteotomy.
I prefer to use the curved punch, Carrington punch, to remove this part.
Yes. Dissector. Okay, now this is the disc here, contralateral side of disc. Maybe we will remove a little part more. Tur ver. Tur. Suyu kapat. Suyu kapat. Boşalt. Kapat. Boşalt. Kapat. Boşalt. Kapat. Boşalt. Kapat. Şimdi ben aref ver. Evet, osteotom. Ne kadar zamanımız var? I think we are time okay, right? We have time. Okay, vuralım. Vuralım. Vuralım. Vuralım. Ver bakayım kartonu. Pardon. Karşıya bakalım. Okay. Efektör alayım önce. Şimdi foraminal keresini isteyebilirim senden. Here is the foramen, just here. Bir numarasını alabilirim. Aref.
we all know that the axillary area of the
Yes.
root,
This is excellent.
there is too much vessel and too much the fat tissue. So maybe there is too much the bleeding.
Yes, you're right. It is good science, actually. This means that we are so close to nerve roots also. Here, the nerve roots.
When you use this curve probe, what's your setting? 2211, what's your setting?
Sorry?
For when you use this curve radio frequency, what's the radio frequency energy setting? Is it
I change. Yes. When I see the Dura, I always using the low level energy. For example, we are using the Bones brand radio frequency device. The coagulation is 2 and the cut is 3 level now. Okay. But it's very change. Yes.
It's very steep.
It's very low. Steep. Yeah.
This is also bounce radio frequency.
Sorry?
I mean, the curve, the radio frequency is also produced by a bounce company.
Yeah, there are many of different companies, but we are using the Bones brand, no problem.
I think Bones have curve, they have hook-like, they have all kinds of patterns for us to choose which one we want. Yeah. But it's very nice. I like this curved one actually. I usually use the ball tip one, which is not so wide the area of radio frequency. Maybe we should use this curve larger area one.
Sometimes it's easier to for me to insert the bigger size radio frequency through the work portal, but for the small size radio frequency, sometimes it's difficult to insert the work portal.
Yes.
So I think the hook type one is good because it's very big, but the tip of the radio frequency is small. But the hook part is very short. You can change the 30-degree endoscopy.
Yeah, I think almost completely decompressed at the sector.
So this one, I mean, if we use the 0, you can see now we can see the exiting nerve root, but we see the bottom of it. If you use a 30-degree, you can see more. You just see the shoulder of it. But essentially, when we decompress, we probably just need the bottom of the nerve root as a reference. So it's not absolutely necessary to have a 30-degree scope, in my opinion. But I mean, that's my opinion. Yeah.
Yes, the 30-degree always should be ready. But mostly the 0 is enough for everything. Mostly the sector. This is the lower foramen here, and the disc level, the upper foramen, and this is the scoliotic and narrow side, and here is the pedicle. Maybe we can remove more this disc a little bit more from here. Okay, then we will finish. Okay, ekartöre ver bakayım.
When we do the contralateral decompression, the position of the portal is very important.
Yes.
If you use the 0-degree endoscopy, the position of the two portal will be lower. I think is more comfortable for us to do the decompression.
Çekme. Tamam. Çıkabilirsin. Bir sektör alayım. Yes. Now it's okay. Okay. Let's see the other sides. Ver bakayım ben foraminal keresini. Yok, foraminal değil.
Now Dr. Hayati is doing the obsilateral decompression.
Yeah. Actually, no need, because this side is good, no problem, but also want to remove the flavum from here. Okay. Got it. Foraminal keresini alayım. Büyük olanı.
Teacher Zhang, Professor Zhang Wei, do you use 0-degree endoscopy regularly? And share your experience.
For me, for this case, if I do this case, I often choose the 30-degree endoscopy. But if I use the 0-degree for the contralateral side decompression, I will remove more the obsilateral laminar. Then the bone of the obsilateral laminar will not block my surgical field. And I will move the position of the two portal more lower. Then I can see the contralateral side, the double nerve root clearly.
Good.
But I think Dodson prefer to use the 0-degree endoscopy, but the direction of the 0-degree endoscopy is very important. He often use his hand to know the direction of the endoscopy, and they also use the cleft between the obsilateral flav ligament and the contralateral flav ligament to know the direction of the surgical field. But I think there is easier for us to use the 30-degree to know the direction.
Suyu mu bitti? Bu suyu bir bastırın.
Okay.
Bir bastırabilir
Yok
miyim?
yok bastırmayın gözükmesin.
So I think
Often use the 30 degree endoscopy when he perform the thoracic disc herniation. He introduced this skill in his presentation. But for the fusion case, 30 degree endoscopy is very useful, especially when we deal with the end plate.
I would like to ask a question to all panelists. Can I ask?
Of course.
Okay. When should we prefer contralateral sublaminar approach or paravertebral approach for foraminal pathology? For foraminal pathology.
Very nice.
Which way?
Yes,
Yeah.
actually the master son should give answer for this question. Yes, in my opinion, if the problem is exceed the half of middle half of more than half of the lateral side of the lateral side, you should go the paravertebral. But if the problem or compressive area less than 50% or the close to medial side, you can go the paravertebral approach.
Okay. Thank you.
Okay.
I use the pedicle. The pedicle is a nice circle. So if compression is just at medial lateral recess, and then at the tip of the pedicle, midpoint of the pedicle, you can do a contralateral approach.
Okay, we finished the surgery.
Pedicle to lateral aspect. Beyond that, then we use the far lateral approach.
Now we finished the surgery. If you have any question, please ask.
Dr. Hayati, do you use drain after the surgery?
Drain?
Yeah, drain.
Yes, always.
Always.
Actually in decompression, I always prefer the putting the drain. I will put line. Okay, this is our drain. Okay.
Dr. Haman, you don't use drain, right?
Yeah, sometimes I don't use drain, but after I evaluate my cases, I think you should use drain.
Okay. Thank you for your watching.
Very nice job, Dr. Hayati.
Yeah, yes, very nice. Thank you for great surgery. Thank you.
Thank you. Great. The surgical demonstration. Thank you, Dr. Hayati. That's a
Thank you
great
very much.
operation.
Thank you.
Thank you very much.
Okay, thank you very much. This is
thank you. Congratulations.
Okay.
The contralateral sublaminar approach is a good approach. It can avoid the happening of the fusion the fusion procedure because we can see the operation we preserved the both sides of the facet joint, so we can do the decompression of the double nerve roots of the contralateral side. So is a good approach, I think. For this operation, the first dock is apsilateral junction of the spinal process and the laminar. Then we remove the basement of the spinal process, and we can see the cleft. Then we remove the apsilateral flap ligament and remove the contralateral side, the flap ligament. First, we do the decompression of the contralateral, the corner. The corner area is very important. Under the corner, you can see the medial margin of the pedicle and the nerve root. Then we remove the contralateral side of the tip of the SAP. We can do the foraminal decompression. In the axillary area of the nerve root, exiting nerve root, there is too much the vessel and the fat tissue, and they are also important the landmark. If we see the vessel and the fat tissue, we know the position of the exiting nerve root. After removing the tip of the SAP and the dorsal, the foraminal flap ligament, and the axillary area, the disc, we finish the contralateral side of the decompression. Then we can perform the apsilateral decompression. This is a whole procedure of the demonstration, surgical demonstration. Great operation.
Hello. Good afternoon, everyone. I have a question. My name is Dr. Timuchin. I'm from Mongolia. So I would like to know about the doctor's personal opinion about the dural tear. So during the surgery, if somebody will with the dural tear.
Yes, for the beginner is a common complication. For the dural tear. The first thing I think is you must keep the clear surgical field, and you can control the blood pressure, and you can use radio frequency to control the bleeding. And another thing is how to deal with flap ligament. The flap for the severe stenosis case, there is too much adhesion between the flap ligament and the dura. You must detach you must touch the gap between the flap ligament and the dura. And if you meet with the dura tear, if the size of the dura tear is less than 4 millimeter, you can finish the operation as soon as possible, and you must keep the outflow fluidly. If the size of the dura tear is very large, I often do the dural suture to close the tear. It is similar to the open procedure. You often can cover the dural tear by the gelatine sponge, and the drain is must be to insert to the surgical field.
Yeah, I agree with Dr. Zhang Wei. So Usually the dural tear, it happens when you use the kerosene punch. So be careful while using your kerosene punch. Don't see what you cannot, don't cut what you cannot see. So I agree with Dr. Zhang Wei. I always take down the flavum ligament en bloc as possible, because back then when I take down the flavum ligament using piecemeal, that's what I experienced the dural tear. So when I changed my technique to en bloc resection, I haven't had any incidence of dural tear.
You must know where is the severe adhesion between the flavum ligament and dura. I think, in my opinion, in the area of the, for example, L4 and 5, the upper part of the basement of the spinal process of L5, in this area, there is too much adhesion between the flavum ligament and the dura. So when you remove the basement of the spinal process of the lower part, you must be careful. This area is very dangerous, I think.
Yes, I'm completely agree with you guys, and thank you for your opinion.
Yeah, and I think one more, Dr. Hayati shows us using cutting burr. So I think you have to have a very skillful hand and experience while using the cutting burr. So I suggest for you guys, beginners using the UBE, I suggest you using a diamond burr. It's safer compared to the cutting burr.
Yeah.
For the position of the contralateral sublaminar approach, can I show my screen?
Yeah, sure.
Okay. Can you see my screen?
Yes, we can.
Yeah. For the contralateral sublaminar, you can see the endoscopy portal and work portal. They are more lower. So for the endoscopy portal, if you place the endoscopy more lower, you can see the contralateral side, the lower margin of the pedicle. And for the work portal, it's also easy. The angle of the kerosene punch is very good. So I think this is a very important skill for this approach.
Yeah, Dr. Zhang Wei, you have a blue one and a red one for working portal. So the blue one is which one do you do for working portal? You have two circles here.
This blue one is under the upper part, the pedicle. So I refer to the endoscopy portal in this line, in this blue line.
I'm talking about the working portal. You have a purple color one more lower, and then got one blue color one more higher. Which one you use for what purposes?
Pardon?
You see you have two circles at the working portal. One is a blue color, one is red color. Which one do you use for contralateral approach?
This red one is a work portal.
Okay.
This green one is a common procedure portal.
Okay. Okay. So it's a bit lower, you are saying.
Yeah. Yes.
Okay.
But for the ULBD, the common ULBD procedure, I prefer to the green one, this one, because we sometimes the basement of the spinal process often block the kerosene punch to deal with the contralateral side corner.
Can you show us the right side approach?
This is a translaminar approach for the disc herniation fragment migrate to the lower part This is another approach, contralateral side approach designed by Dr. Sun. But for this translaminar approach, we must remove more part of the basement of the spinal process. But if I use the contralateral side transporter, I will not remove more the basement of the spinal process.
No, I mean, what you show is for the right-handed surgeon left side approach, right? Do you use the same portal if you are using the right side approach to address the contralateral
More
left
lower.
side?
I think more lower for the right
lower.
side approach. More lower.
Yep. Okay.